Okay, good evening. Welcome to the MyCP webinar series, where we do a series of community-focused presentations of research going on in the Cerebral Palsy Research Network. My name is Paul Gross. Tonight, we're going to be talking about the feasibility of adding grip strength as a measure of body compensation to assessments of people with CP. And I'm very pleased to have Dr. Ed Hervitz, who's the chair of Physical Medicine and Rehabilitation at the University of Michigan, present his research here. So the agenda, as usual, is going to be just a quick overview of the CPRN for those who are not familiar with it, and MyCP. And then we're going to talk about the grip strength and body composition feasibility study. And then Dr. Hervitz will be available for Q&A. Okay, so the Cerebral Palsy Research Network, or CPRN, has as a mission to improve outcomes that people with cerebral palsy value most through high-quality clinical research and quality improvement initiatives. The reason why I underline people with cerebral palsy value most is because in 2017, we went through about a 6-month process of engaging the community, the extended community, both people with CP, caregivers, and clinicians and researchers, in actually coming up with a research agenda, and that is what drives what our work is about. So CPRN is a little bit hard to wrap one's head around conceptually. It is a collaborative network of institutions, hospitals and their associated universities, clinicians and therapists and researchers affiliated with them, and patient advocates all working together to conduct research to improve these outcomes. Physically, we have a data coordinating center, a place where the data for our research comes together at the University of Utah in the Department of Population Health Sciences. And we really the network works on both building infrastructure and bringing people together to do research. The core infrastructure is a series of registries. We have a clinical registry. So a registry is really just a database. And in this case, the clinical registry is one that characterizes the people that are coming into the hospital, so they are patients in this case, what interventions they get and what their outcomes are. And what's very special about it is it's built into the medical record. So the physician is interacting with you and interacting with the computer as they do. That interaction is what produces their clinical note, but it's also capturing that data for use in the network. The second registry is a community registry, i.e. it's something for people out in the community, independent of whether or not they're a patient per se, and it allows them to participate in research through surveys. Both of these registries are longitudinal, meaning we're tracking people from as soon as they enter the registry, which can be as early as about 14 weeks if you're at Nationwide Children's Hospital and you get an early diagnosis, all the way up to any time you could enter into one of our sites across the network at any age. So that's what CPRN is. MyCP, or My Cerebral Palsy, is really a web portal. It's really a platform that CPRN operates for the extended cerebral palsy community. What it does is it gives you a chance to, as I said, participate in that community registry through surveys. And there are surveys the surveys get targeted for the little bit that we know about you when you sign up. So we have an adult survey running now about personal well-being, function, and pain. We have a number of parent-focused surveys running right now. It also provides an opportunity to have discussions about research and about the evidence for various treatments and share elements of your lived experience with cerebral palsy. And this is a place where not only community members are engaging, but clinician researchers are engaging. So it's not uncommon for Dr. Hervitz to be answering a question about the evidence base for a given area of CP, or for Dr. Bumo, it was actually Dr. Kruer was just on answering some questions about his genetics study and genetics in CP. So great place to have interaction. And then it provides news about the work that we're doing in CPRN, and we're starting to build out a series of tools to help you navigate your cerebral palsy and your interaction with the clinical community. Anybody can sign up. It is free, and it is at mycp.org. So as I said, we really are infrastructure for accelerating research. this pipeline represents the research that we have developed so far. So on the left, you see the wide end of the funnel where we have ideas that people are developing, and we ask them to do a review of those ideas. Those ideas have to fit along the research CP patient prioritized research agenda. If they get approved, they move on to try to get funding and get implemented as studies. Eventually they get written up and they get published. And then over time, what CPRN is trying to do is roll the best practices that are learned back into the system so that it's a continuous learning platform and getting increasingly better on research. And you see there's one that's got like a gray shadow here, and that is the work that Dr. Hervitz is going to be talking about. He's gotten approval, he's gotten funding, and he's working on implementation, and he'll give you the details of that. So the network is spread across the country. The green pins represent sites that are actually collecting data into the registry today. The yellow pins are doing the work to prepare the registry. Because it's a database, there's a fair amount of information technology that's involved in it. The red ones are in the compliance phase. They're getting approval for various data transfer and whatnot. And then the blue sites are sites that have expressed the interest and are taking the steps to become members of CPRN. So we've got 28 sites that are either green, yellow, or red, and probably about 8 or 9 sites that are signed up as candidate sites. They're not all reflected here. So we've got a lot of sites with interest. So without further ado, I'd like to turn it over to Dr. Hervitz, who is both a professor and the chair of the Department for Physical Medicine and Rehabilitation at the University of Michigan. He's a pediatric physiatrist. He's a member of our executive committee, which helps steer the direction of CPRN. And then he's the co-director of the Cerebral Palsy Research Consortium of Michigan, which he's done a lot. It's got a great set of colleagues and it's done a lot of bodies of work from that. And he is both a study leader and a quality improvement leader within CPRN. So he really donates a lot of his time to improving outcomes through research and quality. So with that, Dr. Hurvitz, I turn it over to you.
Thank you, Paul. Are you able to see my screen now with the in the slide
view? Yes, I am.
In the show? Oh, great. Okay, good. Good. Well, welcome everybody, and it's just my pleasure to come today to speak at this webinar. Many thanks to Paul Gross, not only for inviting me for the webinar, but for all the fantastic work that he does for the Cerebral Palsy Research Network, which I have expressed many times, which I think is probably the most important thing that's been going on in my professional career, and certainly in cerebral palsy research in all the time that I've been involved in it, which has been quite a few years. So today I'm going to talk about a study that we want to do called Feasibility of Adding Grip Strength Measures to Body Composition Assessments in Individuals with Cerebral Palsy. The study group is listed below. Several individuals from Michigan Medicine, the University of Michigan, and the Department of Physical Medicine and Rehabilitation. And the study is funded by the Foundation for Physical Medicine and Rehabilitation. I have nothing to disclose with this study. So this is Mr. Russell Thompson, and I met Mr. Thompson in the effort that Paul talked about, the research CP effort. And I'm quoting him here to answer a question: what do adults with cerebral palsy want to know? Mr. Thompson said, "My biggest challenge is understanding what is happening within my body. It appears over the last couple of years that my muscle has deteriorated. I expected some deterioration, but not quite this early. I'd like to determine if this is reversible or how much it will worsen." The other thing I want to tell you about Mr. Thompson is that at Research CP, Mr. Thompson looked at me when I was up and talking, and I just mentioned that I do research on adults with cerebral palsy, and he said, "Tell me about your research. Tell us all about your research." And I was a little challenged about what to say next, because it's a little bit difficult sometimes for me to talk to adults with cerebral palsy, people with lived experience, about my research, because The focus of our research has been the risk of chronic disease. And when it's all presented all together, it doesn't always sound that great. It doesn't always give the best window of hope and opportunity. But one of the things we want to talk about with the study we want to do today is how we start turning that work, using that knowledge, and knowledge is power, and using the power of that knowledge to help us to kind of turn things around and to get to the point where our research is in a more positive direction for people with cerebral palsy, rather than just describing the problems. So let's start off by talking about body composition, which means what we're put together out of, and strength. So we'll start with children. Children with cerebral palsy have an altered body composition, and they have a low level of strength. They have a high fat percent. They have more fat in their body than really should, and low fat-free mass. Fat-free mass refers to the parts of your body that are not fat, and that's mostly muscle and bone. There's high levels of fat within the muscle. That means for every bit of muscle they have, there's fat, and then that makes the muscle less effective. It may look like they have a lot of muscle, but it's not as strong as it should be because there's fat in the muscle. There was a study called the On Track study, which followed children 6 to 12 as they aged and showed they lost strength, endurance, and balance. So body fat in individuals with cerebral palsy is a problem. Now, it's also a problem in terms of how we measure that body fat. I have that picture here. It's a famous picture looking at body mass index. Two individuals that weigh the same, but you see one is mostly muscle and one is mostly fat. However, their body mass index, a measure that puts weight over height, is the same because they have the same weight and the same height. So we see that that's not a very good measure. And it's also a problem for people with cerebral palsy. Let me demonstrate with this picture. This is a DEXA scan, a scan of an individual, an adult with cerebral palsy who I take care of, who's a very healthy fellow in his early 40s. And we can see that by looking at what his body is made of, which is what the DEXA scan does, when we look at his BMI, his height and his weight measure, it's right here in the normal range, in that green area that says normal, falls right into there. When we look at this orange graph over here that looks at his body weight percent, his body weight is in the top line, in the 90th percentile. We also can tell from this DEXA scan that his bone density is low. His bones are weak, so to speak. So this means that even though his body weight for height, BMI, is in the normal range, he really has too much body fat, and he has a low level of bone and muscle. So even though his BMI is normal, he really has a high risk of cardiovascular disease. So BMI is not a good way for us to follow people with cerebral palsy, even though it's the way that most people are followed in their doctor's clinic. So adults with cerebral palsy are at risk for chronic disease, as I mentioned. Our research has found out that they have a higher risk than people who don't have cerebral palsy for cardiovascular disease, renal or kidney disease, musculoskeletal disease, meaning arthritis and bone and joint problems, respiratory disease, problems with the lungs and breathing. Well, the common pathway for all of these problems is inflammation, what we call the inflammatory state, inflammation in the body. And people who are obese, people who have poor levels of fitness, people who don't exercise and move around enough, they have a high level of this inflammatory state. And this is one of the things that may be contributing to the high risk of chronic disease in adults with cerebral palsy. In cerebral palsy, as I mentioned, muscle gets replaced by fat at a much earlier age than would be expected in adults who don't have cerebral palsy. So for example, this is a picture of an ambulatory boy with cerebral palsy over here, and a typically developing boy, and it's an MRI scan done at the same level. And you see how much more muscle there is in the typically developing boy compared to over here, picture A, the boy with cerebral palsy. And the graphs here just talk about the amount of fat. The first graph says that there's more fat in the muscles of children with cerebral palsy. And this second graph shows there's more fat in the bones of children with cerebral palsy. So these children grow into adults with the same problem. So our critical clinical question then is, given the documented loss or absence of lean body mass, muscle and bone, and increased storage of fat tissue, is there an increased risk for chronic diseases in adults with cerebral palsy? And so, as I mentioned, the answer is yes. This is from something we published in the Journal of the American Medical Association, JAMA. And we see the yellow bars are people without cerebral palsy, and the blue bars are people with cerebral palsy. And in every one of these categories, diabetes, asthma, hypertension, heart problems, stroke, emphysema, joint pain, arthritis, people with cerebral palsy have a higher risk of the chronic disease. We also looked at physical activity and sedentary behavior, putting together findings from several studies. These tall bars over here show sedentary behavior along the levels of the gross motor functional classification scale, with the darker blue bar being level 1, people that walk around more, and the lighter blue bar being level 5, people that use a wheelchair all the time. And we find that people with cerebral palsy have a tremendously high level of sedentary behavior and low levels of even low physical activity, and certainly moderate to vigorous physical activity. So sedentary behavior combines with the changes in body composition that we saw, the fat in the muscles and the fat in the body, to really increase risk of chronic disease. So here's some things we don't know. We don't know the natural history of the risk of chronic disease. We don't know how these chronic disease issues play a role in the high levels of pain that we see in cerebral palsy, in the well-documented problem of functional loss, people losing their ability to do functions like walking or just other functions in life at earlier ages. We all lose some function as we get older, but people with cerebral palsy start to lose that function at a much younger age. The phenomenon we call early aging. We don't know the natural history of these problems and how chronic disease risk plays a role in them. We also don't know if we can change that chronic disease through intervention. We generally think we can, because we certainly can do that in people without cerebral palsy, but how does that work in people with cerebral palsy? We also do not know the best tools for screening for chronic disease risk. The studies of body composition are often complex, like I showed you the DEXA scan. Well, DEXA scans, I can order them, but they're not available in my office. You have to go to radiology and get them. You have to have a good reason for doing them. And other factors aside from body composition play a role in chronic disease risk. For example, strength. So grip strength is an established biomarker of health. It's one of the simple ways we can tell how healthy someone is. It's not really well tested in cerebral palsy. It's highly correlated, however, with other measures of strength, like looking at how strong the person's knee kicking is, or other parts of the body. Grip strength tells us a lot of information about their strength overall. A weak grip is associated in people without cerebral palsy with an increased risk of functional disability, loss of function, fracture, heart disease, diseases of the muscles, skeletal and bones and joints, and early mortality, early death. And in children and adolescents, it's associated with metabolic health problems, with heart problems in children and adolescents if they have low grip strength. So the goal of our study is to test the clinical feasibility. In other words, how easy it is to do in clinic and how reliable it is to do these measures in clinic, how correct they are. These measures, certain measures of body composition and strength performed in a clinic setting on individuals with cerebral palsy. Again, we don't want to necessarily send people for DEXA scans or other complicated measures. We want to do some simple things in clinic so we can understand patients' risks for chronic disease. Our long-term goal will be to have a set of measures that can assess risk and then the effects of intervention on risk, and then to incorporate those measures in the Cerebral Palsy Research Network. So we can look at a large group of individuals with cerebral palsy and get some idea about this chronic disease risk and what we can do to help decrease it. We're talking about intervention, not just for adults, but for children and adults. What can we do for children so that they grow into adults who have less risk? And what can we do for adults who are already adults to decrease their risk? Research CP, the effort that Paul talked about that I referred to earlier, where we got researchers, clinicians, and people with lived experience together to talk about research priorities in CP, identified some of the work that we're looking at now as being top priorities. So one of the top priorities was researching issues around aging with cerebral palsy to understand not only how to treat adults now, but to update our treatments and therapies with children who have cerebral palsy to prevent some of the secondary impairments, such as pain, fatigue, and functional loss. And then understanding the best long-term exercise and strength training strategies to improve activity, participation, and health, minimize pain, and maximize function in each of the gross motor functional classification scale categories across the lifespan. So our research is aimed at the beginning steps of how we do that. So our aim one is to assess body composition during a clinic visit for children and adolescents that's ages 8 through 17 and adults with cerebral palsy. We can't really go below 8 years old with some of the measures we're doing, so we're starting with 8 years old, and we'll see if we can get any younger than that at some point. So we want to do easy, inexpensive, and time-efficient measures that are commonly used to assess body composition. So we'll measure weight, but we'll also look at waist and hip circumference, and then take the waist to hip ratio. I have an image over here that talks about the waist to hip ratio. And the basic idea is to take a measure around the waist and a measure around the hips, and then do a ratio of waist to hip. And you see the numbers over there. In a man, anything over 1 puts a high risk of health problems, and in a woman, over 0.9. So those numbers tell us a lot about health and risk. We actually did a study where we looked at waist-hip ratios in adults with cerebral palsy, and we found that it was very well correlated, much better correlated than body mass index with their cholesterol levels and measures of risk. All we need to do this, and then we also want to look at skin folds. Doing a measurement on the triceps and on the calf, on the lower leg, is another way for us looking at body fat percent. And you see the image there of how a skin fold is done. So we need a height and body mass scale. We need measuring tape and skin folds caliper. Simple, relatively inexpensive equipment that anyone can have in clinic. Our second aim is to have grip strength measure to assess strength. And this, as I mentioned about grip strength, it's commonly used, cheap, and easy to implement in the clinical setting. We have a protocol for doing 3 measures and taking the best measure, doing it in both hands and taking the strongest hand. And all we need is this device called a dynamometer. I mentioned the Jamar dynamometer, but I'm not in the market for selling any of them. There's many ones, but that will be the one that we'll be using. And our third aim is to add a self or proxy-reported disease outcomes measure for adults. So basically, we're going to do a chronic disease assessment, looking at some of those diseases that I mentioned are at higher risk for adults with cerebral palsy. And we're going to evaluate that in this population using an iPad or a tablet. We'll just ask the participant or their caregiver to fill out the survey when they come in. So there's some very obvious questions that I think you might ask me about this study. So I'll ask them myself first. So you might ask, what if I have real strong legs and a core and I have weak hands due to cerebral palsy? Well, won't this study be affected by that? And the answer is yes. Our idea is to see if we can get normalization for people with cerebral palsy, and that will come to include some of these issues about how people with cerebral palsy may have different strength in different areas. As I mentioned, hand grip can be a measure for strength, and we're hoping that hand grip will be a measure for strength no matter where the person is strong. We'll see. That's why we do research, to see if these things work. You might want to ask, what if I have good overall strength and one weak arm and hand? Well, that's where we're going to do both hands, so we can get your strongest results. And here's a question everybody asks. Well, if grip strength is so important for overall health, should I start doing grip strength exercises to make my hands stronger to decrease my risk? Well, there's 2 answers to this question. The first is, you should do all kinds of exercises to make yourself stronger. And you should do grip strength exercises to make your grip stronger, because having a stronger grip will make you more functional and allow you to be able to do things. However, if you do better on grip strength testing because you worked on making your hands stronger, that doesn't necessarily change your risk. So won't the study be effective at people who do work on their grip strength? The answer is there aren't that many people out there who just sit and work on their grip strength and don't work on the rest of their body strengthening. So we're hoping that grip strength will continue to be a good measure of overall body strength, as it is with people without cerebral palsy, but we'll have to see. Our future plans, by adopting these measures as routine, we can start to develop public health surveillance for chronic disease development throughout the lifespan for individuals with cerebral palsy. And we can do further testing to assess if these measures are responsive. That means, do they change when we do an intervention? And does it reflect that the intervention is changing the health and the risk? So that's some of the future studies that we'll need to do. We have a vision for care for adults with cerebral palsy. We want to determine best practices for clinic practice. That includes surveillance for health risks, pathways for treatment and intervention. And We want to do patient-centered care with lifestyle intervention. We want our clinics not to be about your blood work or about your braces. We want it to be about your lifestyle and how you can lead a healthier and more functional life. We want to expand care. We want to use technology for greater reach. Eventually, we want to measure risks through telemedicine. I'm a little challenged because measuring grip strength and some of the other things we're talking about through telemedicine is a bit challenging, but nothing's impossible. And we will be thinking about those things and looking for other ways to measure risk via telemedicine. And we want to educate and build knowledge and interest in this topic. We're doing a project, a quality improvement project, as Paul mentioned, relating to adults and looking at the clinic. Our project goal is to improve the health and quality of life in adults with cerebral palsy. And we want to ask, how well do we do assessing function and pain in clinic visits? And how can measuring function and pain help us to understand the causes of pain and functional loss? And how can these measures, these body composition measures and strength measures we're doing, help us understand the causes of pain and functional loss? Well, here's Duncan Wyatt. He's here with us at this seminar, this webinar tonight. And Duncan came to speak to us at the University of Michigan for one of our grand rounds. And he told us we have to spread the word. We have to reach out to primary care. We have to teach physicians and PAs and nurse practitioners. We have to help them to understand that information is power. We have to teach other clinicians how to teach their patients and teach how to help people with cerebral palsy stay functional well. So here we are. That's what we're doing here tonight. That's why we're working on this study. These are some initial steps for how we can start to get this done. So that's why I have to say I'm eager to hear your questions. And as Paul mentioned, if you have questions, you can find me on mycp.org. I'm trying to look at that site a little bit more so that I can answer your questions. So I thank you for your attention and interested to hear what you might want to ask.
Great, thanks a ton, Ed. I greatly appreciate that. So let's open the floor to questions. I think what we can try is people can unmute if they want to ask a question live, or they can post a question in chat. And if we step on one another, I'll call people out, but we'll see how it goes. Questions don't usually come fast and furious. But I will start with the question since there isn't one just yet. So I have seen charts that I want to say were developed by, I want to say in California, maybe by, trying to think of the health system, Kaiser Permanente, but that took growth and height curves and then got a lot of data and applied them to the cerebral palsy community. Is that something that, from your perspective, if that's in use in practice? Like, I was very interested to look at that and kind of, look at my son relative to that. Are those in sort of a standard practice from your perspective for pediatrics for kids with CP?
That's an interesting question, Paul. Kennedy Krieger has developed those kind of charts as well. And I believe there's at least one other place that's developed these charts. I'm not sure if I would say that they're a standard practice. I'm not sure I can really say that, when we look at the research that's presented at the American Academy of CP and Developmental Medicine and so forth, that it's something that is commonly used and commonly talked about. They're out there. I don't know how well they've been tested. It's something that we should probably take a better look at. And it's a useful idea. The charts are divided up by gross motor functional classification scale because someone who's ambulatory, someone who walks around, is not going to be on the same chart as someone who uses a wheelchair, because we talked about someone who uses a wheelchair all the time is going to have less muscle mass than someone who walks around. So those charts will be different, but they usually try to divide those up. They're a lot of work. They take a lot of work to make. What we'd love to do someday, as we spread grip strength through the CPRN network, is to make grip strength charts for people with cerebral palsy and divide them up by GMFCS as well.
Great. I could fill the rest of the hour with questions for you, sir. So I'll wait and see if somebody else is going to unmute. Go ahead, Duncan.
I have a question. Dr. Herbert, particularly at my age, is it your experience that strength training is as important, more important, or less important than the aerobic. Specifically, I do a lot of cycling, recumbent cycling outside during the short summer up here, and then every other day I'm on my stationary recumbent for at least 30 minutes at a time. And yet I have noticed I certainly don't have the strength that I had a decade ago. So any advice there? And along with that, have your team been able to develop any type of preferred exercise or more efficacious exercise?
Well, Duncan, you know Mark Peterson, who works with me. Mark and I joined together with some researchers from the Netherlands a few years ago. We published an article in 2016, guidelines for people with cerebral palsy for exercise. And some of the guidelines are similar to those that we see for people without cerebral palsy, like trying to get 30 minutes of good physical activity a day and so forth. To answer your questions more directly, though, strengthening remains an important part of your exercise program, no matter what your age. And I think that strengthening is often put aside when people get older. They get a little bit afraid of weights, afraid that they're going to hurt themselves and this kind of thing. And I think that's a major mistake, because we don't need to lift heavy weights to build big muscles, but lifting weights in such a way that it just maintains your muscular strength is really important. First off, it's very important for just helping you to maintain and do the activities that you like to do, simple things like getting up the stairs or just lifting things. And secondly, lifting weights is shown to have a good cardiac effect. So our recommendation was that people do resistive training twice a week. Now, I should say that resistive training is not limited to weight lifting. There's certainly the idea of using weight machines, but then you really don't even need to do weights to do resistive training. You can use other things for resistive training. For example, you can use your own body weight doing squats to do resistive training. And one of the simplest ways to do it is with some of those stretchy bands, tying those onto doorknobs and things like that, so that you can pull them and using those for resistance. Simple things like tying them around your legs in a loop and then walking sideways to build up your hip muscles are great ways to do resistive exercises that will build strength and keep a person functional. Aerobics are also an important part, but again, I think it's doing aerobic sessions on a regular basis, but combined with doing some resistive exercises is a formula for health. So I'd highly recommend that.
So unfortunately, Duncan's internet connection left us in the middle of that answer, but I am recording, so he'll be able to get the full bit of your answer there.
And he also knows where to find me. So
yes, yeah. Okay, other questions for Dr. Hervitz?
This
Yes.
is John Malone. I was looking at this, listening to you and basically Dr. Hurvitz, and I'm looking at the role of ongoing therapy in terms of dealing with some of these issues that we're talking about with cerebral palsy, especially as you get older. And I'm struggling right now with a situation of trying to stay in active therapy with a therapist simply because I need the therapist's skill in terms of stretching, specifically in my areas of need with lower body. But I keep running into insurance hurdles in terms of being able to stay there. And I'm just kind of wondering what your thoughts are on therapy in relation to the measures that you're looking at.
Well, John, everybody is different. So let me start by saying that there are a lot of people who feel that they want continuing therapy, but what they really need is better instruction in how to be more physically active and how to do stretching programs on their own. again, I don't know about your particular case, and many people do need the help of a professional therapist to maintain good health and fitness. But what we try to emphasize is figuring out what the person can do on their own with simple equipment, simple maneuvers, and so forth for improving health. However, we have also done some work that has shown that continued therapy can lead to a continued improvement. We did some work with adults where we gave them a board to put in their home to work on their upper extremity function, and we documented upper extremity improvements on adults of all ages. So just goes to show us that we're never too old to get better. So there is a place for therapy and therapeutic exercise, no matter what your age. The issue that comes down to is justifying to our insurance companies that in this particular case, we can't maintain this person's health and well-being without a professional therapist. I think personally, what we need to do is similar to what's going on with physicians. We need to think about some less expensive ways of giving therapy. There are physical therapy assistants. There are other things that can be done to have people that cost less than therapists administer therapy after a trained physical therapist has, licensed physical therapist has recommended the kind of therapy. Somewhat similar to physicians who are, we have physician's assistants and nurse practitioners and so forth. Many of them work with physicians to administer programs that the physician has put in place, sometimes originating their own programs. But I think that we have to think of ways that people can be helped that are less expensive. So I'm hoping we'll continue to develop models that do that.
Thank you. I tend to agree there need to be less expensive ways to do it, and I'm finding it difficult to break through the insurance barriers. So I would welcome something that would be more functional than the route I'm trying to take right now.
Right. If you think about it, it's something that you need, but you can't get because the only way to get it is through this very expensive route.
Yeah,
Jackie,
exactly.
I'll have
That's where
you.
it seems to be right now.
I'm sorry, John, I didn't mean to cut you off. Jackie, I'll have you be up next, but I want to ask a follow-up to Dr. Hurvitz. There was a great Pathways to Prevention workshop that you participated in last week, run by NIH. And I'm wondering if, and you may not have enough detail to answer the question, but do you feel like the kinds of programs that there was a person that runs, I think his name was Devin Palermo, and he's based out of Fairfax, Virginia, but he runs an adaptive exercise program. And if you think there's an opportunity to use that kind of model to potentially help people like John transition, because it's really set up to transition from therapy into doing health and not just rehabilitation. Do you think there's a potential for that to be a broader model that we could address, some of the community's needs in this regard?
Yeah, that's exactly right, Paul. That's kind of on. Again, it won't help everybody. People are individual, and they have to be treated and looked at individually. And of course, one of the problems we run into is that sometimes insurance companies will look and say, oh, well, we have these new kind of approaches, so we're going to throw out the old approaches. But yes, I think there's a lot of ways to get at this problem, and certainly the kind of work that gentleman was doing is one of those ways. One of the top barriers to exercise for individuals with disabilities, and certainly with cerebral palsy, is accessible equipment and people with knowledge, the level of knowledge needed to help them to use the equipment and to advise them on ways to do exercise. And especially many people with disabilities are afraid that they're going to get hurt when doing exercise, and not just themselves, but often the caregivers they deal with are even more afraid, especially for people with cerebral palsy, who often, in their younger adult years are still perhaps with their parents. Their parents are deathly afraid that they're going to get injured themselves if they try and do anything. So having more knowledge about that is something I think that's really important. So growing the knowledge is going to be one of our biggest goals. I'm really excited about the growth of adaptive sports in general in America, and just the variety, the broad variety of adaptive sports. We have programs at the University of Michigan in wheelchair tennis, in adapted kayaking, you name it, all kinds of things. And I think that you know, one of the chief barriers we all have to physical activity is that if we can't find something that we really enjoy doing, it's just so darn boring. You know, the idea of individuals who are unable to walk, sitting and doing the armagometry, it takes a real hero to sit at one of those machines and just keep cranking away, even though it's good exercise. So finding exercise options for people that are healthful, that are safe, and that are interesting, that are fun, I think is going to be something we'll continue to do. And I think that program was really aimed at that.
Yeah, no, it was fascinating. So I feel bad that I asked that question, knowing that Jackie McTaggart is in Scotland and is up late. Her hand is up. She's probably getting tired. So Jackie, go ahead. You can unmute. You can ask your question.
Hi, I'm really interested. I'm actually a clinical research nurse, but I also have cerebral palsy. I only found out when I was 44 that I have cerebral palsy, and I also have some of the other comorbidities that you mentioned. So I've got kidney disease and hypertension. I am shocked about the DEXA scan. I have never had that mentioned, that can happen by any health professional, and our access to health professionals is really poor unless you've got severe CP. So what I was kind of interested in, the grip strength stuff, does that actually reduce the fat mass in the DEXA scan?
The grip strength won't tell us a lot about fat mass. It tells us more about muscle mass and muscle function. Or the waist-hip ratio, the skin folds and so forth, we hope will be something that will approximate what the fat mass in the DEXA scan, and will be able to tell us more about people's fat mass. You know, it's interesting, Jackie, that we did a study where we looked at the waist-hip ratios, and we looked at people across all of the gross motor functional classification system levels. And we found that people who were ambulatory, who walked, that class 1, that they often had high waist-hip ratios, meaning they had a little bit too much tummy for their hip size. But then when we looked at people that were wheelchair users, that were very small, very underweight, looked like they were very underfed, what we found is that their waists were smaller, but their hips were even smaller, and they also had a high waist-hip ratio. So waist-hip ratio was a pretty good measure for looking at, does someone have too much fat, and do we have to start talking about them from a dietary point of view, a nutrition point of view. You know, having said that, one of the things I want to point out that I think is one of the large problems we have with cerebral palsy is that because individuals with cerebral palsy, kids with cerebral palsy, have less muscle mass and less bone mass, they're always at the bottom of those weight curves. And Paul talked about the CP weight curves, which is why we probably should be using those more, because their pediatricians are always telling the families to give them more calories, because they're they're below the 3rd percentile for weight and height. Well, we know that people with cerebral palsy are going to be below the 3rd percentile, especially for weight, because they don't have the muscle and the bone mass. They're also going to be lower for height because their bones don't grow as well as individuals who don't have cerebral palsy. But they're perfectly healthy. And when we feed them to try and get them up onto those curves for people who don't have cerebral palsy, all we're doing is adding to the fat mass, adding to the problems they're going to have later in life. So I spend a lot of time telling parents and writing letters to pediatricians, telling them to leave the poor child alone. As long as he's growing along his curve, he's doing well. We don't want to add to his fat mass. We don't want to make a fatter kid. That's why measures like waist-hip ratios and looking at things like skin folds, we hope will be helpful to help us understand the relationship between body fat mass and the rest of the body for individuals with cerebral palsy.
Thank you. That was really helpful. I wish
You're
you were
welcome.
doing the study in Scotland.
Dr.
Thank you.
Hurvitz, Duncan again. Are you aware of any programs that are using the Peloton model in terms of some virtual contacts with people with disabilities to do exercise programs where there would be some social involvement through a
What an
virtual?
excellent question, Duncan. You know, I mean, I can really hear the points. You know, a lot of individuals with disabilities can't exercise at the level that the Peloton programming demands.
Right.
You know, that heavy level. So can we do something more that is more at an adapted level for adaptive functioning, and make it a social experience? You know, I always talk about the fact that one of the barriers to physical activity, and I keep saying one of the barriers because there are many of them, one of the barriers to physical activity for people with cerebral palsy is often related to the fact that many people enjoy physical activity in groups, in socializing. I personally don't, because I don't think I look great in exercise clothes. But many people do. Many people like to play team sports, or they like to jog with someone else or something like that. And now there's this new phenomenon of doing exercise in social groupings. So the answer is, I don't know about that, Duncan. It's a very interesting idea. You know, Paul and I have recently had some communications with Jim Rimmer from Alabama, who runs the National Center for Health and Physical Activity and Disability. And, you know, Paul, it's kind of something to think about coming out of NCHPAD in terms of, is there an idea of socialization for people at different adaptive levels to, you know, imagine, because then you can have people all over the world who have certain capabilities. Just like when we talk about, you know, Duncan, you know a lot about Paralympics and Olympics, adaptive Olympics, and you know about levels that people are given this very fancy classification system so that people of different functional levels are put into the same competitive class. Maybe we could do something like that and bring people together all over the world for certain virtually socialized activities. It's a compelling idea.
Well, if you decide to pursue a grant, add me to your grant team.
Will do, Duncan, will do.
Let me see if there are other questions. I've got one that's burning a hole in my piece of paper over here, but I want to make sure other people, I've got good access to you, so I want to make sure other people get their questions answered. Anybody else want to raise their hand with a question? Go ahead, Alex. You want me to unmute you, or
I heard him speaking about the physical activity and how it's tough to deal with, like, affordability with therapy and whatnot. I'm currently doing a program with this group that's called Stay Driven, and they do CrossFit classes every day over Zoom, and it's $20 for membership. It's not necessarily as good as PT or anything, but it's social interactions and we're all exercising, whatnot.
Alex, is that a virtual thing, or is that something that you go to?
It's a virtual thing.
So something kind of like what we were just talking about. That's so interesting. Well, I want to make a comment about that in terms of saying it's not as good as physical therapy. We did a little study with a device called the New Step. Maybe some of you here are familiar with that. It's a device that's actually built in Ann Arbor, and it's a little bit like a recumbent stepper. So it's like a stepper where you sit down. It's a cross between an elliptical and a bike and a stepper. It's something you pedal and move with your arms. And it was really developed by an individual whose wife had a disability with multiple sclerosis. And we put 11 adults with cerebral palsy onto this device, people who were either either not great ambulators or non-ambulators, not able to walk well, and just to see if they could exercise. And we set certain parameters for saying, well, if they did this good with their oxygen usage or with their heart rate, then we know they really did good exercise. And not everybody did, but one of the exercise physiologists in the study turned to me and said, you know, Dr. Hurvitz, in the end, something is always better than nothing. So even if
Yeah.
something doesn't seem as good as physical therapy or something like that, really doing something is always a great idea.
Yeah. And when you're exercising with different people, it's not as much of a chore to do,
Yeah.
and keeping yourself in shape and whatnot.
That's why CrossFit is so amazing. I was able to do things I never thought I could do because of doing it with a group. So I agree.
Can I put like a link in the chat or something
Yes,
for
you
it?
can.
Or?
That would be great if you would. And if not, you
Okay.
can always send me an email. You probably get more email from me than you care to admit, so that's fine.
Yeah.
Yeah.
All right.
Okay. Any other questions for Dr. Hervitz? All right. Well, I'm going to end with one. So, as I've looked at practice variation for indications for selective dorsal rhizotomy, I was really struck by the fact that there were no consistent measurements of strength. And since, you know, the sort of center of the onion for indications for selective dorsal rhizotomy is, you know, ambulatory kids, you know, GMFCS 2 and 3, spastic diplegics. Do you have enough data to know, or would the feasibility study potentially answer how well grip strength is a measure of strength that might generalize into, you know, I hear some physicians, well, they'll hold the kid's hand and they'll have them do squats. But they don't have a set number of squats, and whether or not the squats are done with the right form or whatnot. So I'm curious if you think this will generalize into something that might be an assessment of leg strength that might be important for, if you remove functional spasticity, what's left.
Well, that's a great question, Paul. And you know, our beginning age for this is 8, which is not too old for rhizotomy, but you know, we like to think about rhizotomies at earlier age. And so it's a really great question. One of the things I haven't mentioned, we didn't really write into the grant and so forth, but something we're interested in that we talked about at one of the at the CPRN conference we had in Ann Arbor is about the idea of using these measures for looking at surgical outcomes. So let's put aside the rhizotomy because of the age problem, but let's talk about scoliosis surgery. You know, it's often an issue with scoliosis surgery. Is this patient strong enough to do well with the surgery? Let's talk about SEMLS, you know, multi-level surgeries looking at different muscles and so forth. How will this patient do if we cut their hamstrings, if we cut their gastrocs and this kind of thing? How strong are they? So the idea that the grip strength measure could be helpful in looking at that is something I think that's very interesting to think about. I know our orthopedic surgery colleagues like Dr. Schrader found that a very compelling thought for this study. So we'll be interested to see if that's something that can tell us any information.
It's absolutely fascinating. Well, Dr. Hurvitz, thank you so much for this presentation. I really appreciate you leaving so much time for Q&A. And I think it was a great presentation, and I will share the recording with people that were not able to make it, or so Duncan can get the rest of the answer to his question when his internet connection died. So thank you. Thank you all for attending.
Thank you, everybody. Appreciate your time and attention. Thank you, Paul.
Yeah.